Now we are at the point of our Ask the Expert panel. And we've got 4 clinician experts available today and a lot of very good community generated questions. So I'm going to introduce the group here. We've got Dr. Bill Tapp, Chief of Sarcoma Medical Oncology at Memorial Sloan Kettering Cancer Center. We've got Dr. Burgess at the University of Pittsburgh Hillman Cancer Center, Dr. Chugh from the University of Michigan Rogel Cancer Center, and Dr. Davis, Medical Director of Clinical Trials Office at Vanderbilt Ingram Cancer Center. Thank you all for joining. And we basically make this an open roundtable. So we've collected a series of questions from the community, some very good ones this year. And I'll just ask them, and if you we'll go around and feel free to just jump in and answer. If you've got something to say, that's great. If you don't want to answer that particular question, that's great as well. We've got quite a few to go through. So the first question from the community is, are we getting closer to having any guidelines, standards, and/or tumor size number benchmarks for treatment, or is every case still too unique?
That's a great question. I don't know who wants to field that one. A lot of us have thought about guidelines, and but I'll tell you, you guys have probably learned from this conference that certainly everybody's disease is a little bit different, and I don't think we're quite ready for a one-size-fits-all approach, and we're still kind of tailoring to the individual. But I'd love to hear what my colleagues have to say as well.
Hi, Rashmi. I would agree. The one thing though that's interesting is how collaborative and galvanized the international community is around EHE, and not just the clinicians, but also the patient advocates. And there's an organization that developed a few years ago known as the Ultra Rare Sarcoma Working Group, and EHE has been a main project in a sense of that. And so we have gotten together internationally several times to really talk about all of our treatment approaches and what we think are good paradigms, and a lot of that has been published. And so I do think we're moving in that direction, as Rashmi was saying, but it still will take a little bit more time, and hopefully as we get better and more definitive treatments and understanding of the different disease subsets, we'll be able to do that.
Yeah, I would agree. I think guidelines is probably not the word that I would use, but as Bill said, more of a consensus. I mean, we're certainly better than we were 5-10 years ago. And I think continuing this discussion is really helpful, but I don't know if we're quite there for established guidelines, just because, as Rashmi was saying, there are so many unique cases still.
Yes, I can echo that sentiment as well. And I think if you kind of look at our other ultra rare sarcomas, we also don't have quote guidelines to manage those. It's more consensus expert recommendation. So.
Excellent. All right, our next question. If newly diagnosed, should you start treatment right away to kill the tumor? Is the question from the community. And I know the answer is going to be somewhat, it depends. So I guess I'd also like to clarify that. In what situations might you start treatment right away?
David, you actually took the words out of my mouth. I was going to say it depends. I think just to reiterate what some of the other presenters like Dr. Chen and Dr. Rubin were presenting earlier today, patients that come in that are very symptomatic, whether it's from shortness of breath or pain from pleural effusion or pain from bone lesions, I definitely would want to maybe, talk with patients about treatment in those situations. Patients that present with more of an incidental finding that are asymptomatic, I would definitely talk with them about sort of holding off as a way to value their quality of life. And because the different medications that are available, although none are approved, the ones that are available, do have a lot of side effects. So I always take that into consideration.
I agree with Missy. I wouldn't choose to treat someone unless they were having symptoms or overt rapid progression that was on the verge of leading to symptoms. So.
Yeah, and I would agree. And there's definitely, variants of EHE that can behave very indolently over the years. And I think we all have patients, especially those predominantly that have tumors within the liver and then small tumors within the lung that can remain stable for years, and you can watch them for many, many years without needing treatments. And I think we often question if we intervene, and that's either with procedures that could potentially kill tumors within the liver or medical treatment if we're making a difference. And in some of those cases, when we start medicines, we have no idea if we're helping, right? And you often have to watch someone for long periods of time to even kind of guess if the medicine's helping, right? So we definitely don't want to hurt in those situations.
Any other thoughts on that question?
Well
All right.
said by my colleagues. Totally agree.
Excellent. All right, so the next question. Why do some physicians in medical centers stage EHE and others do not?
I guess I'm not totally sure of the question that the person is asking, but I would say most people when they're diagnosed with EHE will get staging scans. So I'm not sure if that's the question or whether they're asking, why don't we put numbers on it like 1, 2, 3, 4? So I'm not sure which
It's the
type
latter
of
question. Yeah.
Okay.
Yeah.
I would say that, as with sarcoma in general, I mean, I think as an oncologist, we approach it either we can offer a treatment plan with the intent to cure the patient, or we're offering a treatment plan to try to optimize quality and quantity of life. And so I think, staging is one of those things that, while it's important sometimes in how you're thinking about management and how you're thinking about your treatment, actually the fact of whether you're embarking on a curative plan or not is actually the most important thing, in sort of how you talk to the patient.
Any other thoughts on staging?
Yeah, I would agree with that. And like we just said, that some of these tumors present in what we would call stage 4, where they're in multiple places, but that doesn't necessarily mean they are aggressive or going to harm the individual, right? So I think we use those types of staging systems in a lot of cancers, and it carries a lot of weight for patients, but it's not necessarily correct in how the tumor will behave, right? The EHE will behave. So it's really important to understand those nuances.
I think it also kind of highlights that it's really important, because a lot of different words carry some stigma, in the community and the public, that if it's feasible, try to get to a physician or an institution that has a lot of experience with EHE, that can sort of walk you through, some of those, because I imagine, that could cause a lot of anxiety to keep hearing stage 4, even though it behaves, it has the possibility to behave quite differently than stage 4 lung cancer, as an example.
We run into this problem a lot with sarcomas is, it's difficult to put labels that don't have stigmas, as Missy was saying. Individual people aren't numbers, aren't statistics. So we really have to kind of think about the whole context of the disease and not just kind of what label we want to give it or what number we want to give it and how it's going to impact one's life.
All right, the next question we have from the community here is, if on wait and watch, what should we expect is happening? At what point do you consider talking about treatment?
Really excellent questions from the group here. And I think this kind of goes along with what we were, talking about the rate of progression, whether there are symptoms that are present, the volume of the disease. So again, another vague answer from our team, where it's kind of looking at the whole picture and how it's changing in terms of when to make a decision, what is the right time. The other thing is opportunities. Sometimes there's an opportunity, a clinical trial that may make sense. Our trials try to take into account things that we think are important, like a recent study incorporated the use of progression kind of as an entry criteria, so it's a bit more standardized, but those are the things I certainly consider when thinking about treatment.
Any other thoughts on that one? All right, we'll move on to the next question. This one gets a little bit specific, but I think this would be a question a lot of people would be interested in hearing the answer to, if there is an answer. Are oral contraceptives safe for women with EHE? Is there any data on hormonal connection to EHE, pregnancy, or postmenopause?
I would guess that there's not any high-level data on that particular thing, although I would probably bump to my colleagues. But I'm not aware of any association.
I agree, Melissa. I mean, I don't know of any data, regarding oral contraceptives. I can say, this is a disease that often affects younger people and younger women. So, especially in some of the more indolent cases like we spoke about, I think we've all had people who have undergone pregnancies and sometimes multiple pregnancies, and we haven't seen any difference within their disease, right? So again, this is very specialized, and it takes tremendous discussions and collaborations between maternal fetal medicine, oncology, and deciding what's right. But these are discussions we often have to have with patients.
All right, our next question. Are there differences in the way EHE manifests in children versus adults?
I think most of us here are the adult oncologists, so I don't know of any difference or data to suggest. Again, it's a very variable disease even within adults, right? So I'm not as familiar with what happens in children, but I don't know of any data to suggest it's dramatically different.
I can say that I've seen some patients that have transitioned from a pediatric oncologist over to the adult side, and again, small numbers, but was behaving quite indolently like some of the other cases in adults. But it could vary.
We just had a question come in from the live stream here, where the question was interested in speculating on what types of activities might cause EHE to become more aggressive. And then some sub-questions to that: being sick from something else, accidents, stressors, too aggressive treatment. Do we know anything about factors that might cause EHE to become more aggressive?
Really tough questions, crew. I wish we had those answers. I think, we're always looking for an explanation, especially when we see this disease go from indolent to turbo mode. And I think that we've all kind of thought about these things, and as of yet, I have not found a pattern nor seen a description of kind of a trigger. So I don't have anything brilliant to add here. Hoping my colleagues do.
I agree. I mean, I wish I had more to add, but I think this kind of stresses the importance of kind of these natural history studies, these registry studies, just to kind of understand patients' courses, and also, the importance of, if there are trials available, treating patients on the trial, because that's really, when we look prospectively, that's where we collect our best data to try to understand the biology of the disease and how it changes over time.
Great point. I agree.
All right, we've got a question about symptoms. A lot of different questions actually came in and kind of consolidated into this question. People have experienced things like night sweats, itching, fatigue. And the question ultimately is, when should these be concerning and what should be done? Are these things normal? And I will note, I think I saw a very long discussion on the Facebook page talking about fatigue being an incredibly common symptom a lot of people, both symptomatic and asymptomatic, experience. Well, I guess that's symptomatic technically, but otherwise asymptomatic.
Yeah. I think I would put it into context, because of course fatigue is probably one of the most common, reasons to go to your primary doctor. So when you go see the oncologist, we always ask, a bunch of questions like how are you feeling and if you have fatigue. And I would definitely take that into consideration, but I would, if I noticed that on the imaging, the disease wasn't progressing or something like that, and ruling out other causes, I would definitely consider that first. But certainly if there was progressive disease, where we noted some growth in the tumors or new tumors that were forming, that may be an indication, someone experiencing the fatigue. So.
Yeah, I would agree. I think symptoms in EHE are very personal, but also very challenging. And, we speak of these diseases sometimes being very infiltrative or inflammatory provoking, and they often can line some of the surfaces of the body, so they can cause really unique symptoms. And so it's very important for a patient to get to know their symptoms and how they may change. And interestingly, in some of the more difficult cases of EHE, we struggle to draw a line around the tumor and know exactly how our treatments are helping. So we're trying to use symptoms as a way to also understand that, right? If symptoms are getting worse while on treatment or geting better. But some of the common ones we hear are just like you said, fatigue, night sweats. A big one is weight loss and loss of appetite, shortness of breath, right? So these become really important. I don't think a patient should sit on any symptoms. Rather, these are things that you should really discuss with your doctor, so you can understand if there is a level of concern, or towards some of the other questions, would that prompt a discussion about treatment, or whether or not you need an intervention.
We've got another live question from the audience that relates to some of the things we've been talking about here. Is there an amount of growth a person can have in a year and still be considered indolent? For example, 1 centimeter growth in a year is still indolent or more aggressive?
I mean, I think it has to do with the patient's overall burden of disease. If you have one spot that's 1 centimeter and it grows by 1 centimeter, then that's more concerning than if you have, 20 or 30 spots and, a 5 centimeter one grows by 1 centimeter. So we oftentimes will use kind of overall percentage of growth. And, if it's, single digit percentage of overall growth and a person's feeling well, then we may not consider that to be so concerning. So I think it's a complex question, but it's based on kind of the overall burden of disease and the relative growth.
And now that we're seeing a number of treatments, pharmaceutical treatments being used with EHE patients, we're seeing a number of questions about whether there's any evidence or thoughts about any benefits of combination treatments. Any thoughts on that from the group?
So certainly the benefits of combinations are that maybe you're hitting more than one pathway, and there may be a higher chance of benefit if you attack the cancer in more than one way. But the downsides of combinations is, we're adding to the side effects. We don't know if these medications kind of play nicely together and they won't cause, untoward effects we weren't anticipating. Sometimes the medications work really well on their own and give a good quality of life. So, kind of combining medications together really takes some thought and planning and good science and studies. So, in general, we don't do that on the fly. But I think if there's enough rationale, then it's certainly worth considering and moving forward in a study. And I know there's some kind of preclinical work or work kind of even before we take it to the patients going on to try to figure out what are some smart combinations that might make the most sense.
Yeah, I think that was a great answer, so I'll stick with that too.
And I know this question was asked last year as well, but I know we also have a number of new attendees in the audience, and it seems to be one of the most frequently asked questions, and it relates to pain and pain management. And the specific question is, What are the options for EHE pain management?
Yeah, I think this is also a nuanced question, right? And we generally try to think about the cause of pain. And in oncology, it can always come down to, is the pain because of the tumor or the tumor's location, or is the pain maybe because nerves are involved and it's compressing nerves? And I think in EHE, one of the big components of the pain, which is often overlooked, is again this inflammatory component of it. So, a lot of experts and pain management people will go fairly quickly to some stronger anti-inflammatories to really help try to control pain. And that can also help some of these other symptoms that we're talking about. So in my mind, it's really important when we talk about the team around an individual person with EHE, really to have pain and supportive care doctors as well, to think about the nuances of the disease, the symptoms, and how best to maybe help with some of them, including the pain.
And there may be other modalities to help that are not pharmaceutical, because we certainly would consider spot radiation or something like that to help pain management, especially if it was related to the tumor or thought to be.
Are there any, obviously pain is a challenging issue for a lot of diseases. Are there any sort of pain treatment routes that would be you'd want to avoid with EHE, or that would be particularly more attractive with EHE?
I can't think of anything that you would want to avoid per se. I mean, the typical, oftentimes we think about, oral therapies or occasionally nerve blocks, which are kind of guided by the pain management team, those kind of interventional pain procedures. But there's nothing I would per se say that they most definitely have to avoid.
And I would agree. And there's also a lot of holistic approaches. Sometimes acupuncture helps, and other things that can really be important depending on the pain and the symptoms.
All right, so we have I know we're 4 years after COVID, but COVID is still out there and still causing a lot of harm in the world. We have a COVID RSV vaccine question, and specifically any updates on anything related to COVID or RSV vaccines and EHE, or any recommendations about RSV vaccines for EHE patients with lung involvement? And I guess there's kind of two angles to this question. Obviously, COVID and RSV present risks. So thoughts about, and I know this will be a patient-specific question, but vaccination and any special considerations with EHE.
I don't know that I think there's any special recommendations in that, we have to weigh the risks of a vaccine with the benefit. There's no data to suggest that it may, prompt any untoward effect in, EHE or other sarcomas. At the same time, we're learning more about COVID vaccines and timing and the length of benefit. So I think, this is where a conversation with your primary care doctor even may make a lot of sense. RSV, we've seen some tough RSV, and if you're at higher risk or kind of fit within the guidelines, I would say there's no contraindication, no reason not to get an RSV vaccine if it makes sense for your health in general.
All right, so next question. And this goes back to one of the presentations earlier. We learned about the different types of imaging techniques that can be used with EHE, PET scan, CT, MRI. What are your thoughts on sort of best practices, the value of doing multiple different modalities, and any recommendations around whole body scanning?
In general, I try to avoid whole body scanning on a serial basis, I think it's reasonable to do first staging for sure, because you kind of want to know the full extent of the disease. But what I do is I think about where the sites that are involved are, and sort of make a plan based off of the sites involved, and kind of go from there. So I do kind of individualize it a bit. But I think it's, it's difficult to sort of, it's again a risk benefit ratio, I think, with and also unfortunately what the insurance will approve as well. Yeah.
Actually, related to that last point, I know historically there's been some pushback on conducting a lot of PET scans because of the cost. Are you still seeing resistance on that? Because I haven't seen that topic addressed in a while.
I mean, I've been able to get at least an initial PET scan approved for staging. I haven't ran into too many issues. I think it would just be, I assume, pretty difficult to continue, getting PET scans, although I also would question the value of that,
All right, I've got a Dr. Tapp specific question, but although everyone feel free to address it as well if you've got information on this. We, with the emergence of these clinical trials, we did get quite a few questions in this area, and we had questions wondering more about the ICANNA trial and your thoughts, to the extent you're comfortable sharing them, on how IK 930 or any other related compounds can benefit EHE patients.
I think we can all answer the clinical trials in the sense that there are a lot of compounds, and the TEAD inhibitors are one based on, biological relevance towards EHE that we're really excited about. I don't have information regarding, the recent data and what it's been disclosed, but I know it's tremendous interest for us, and hopefully for patients too. Importantly to that is understanding who may be the patients that are actually benefiting from drugs, and what's the best way to understand how the drugs are helping people, right? And I think we spoke about that a little bit because of the nuances of the disease and how we can actually study the drugs to best understand them. But the fact that we as an international community with patients are beginning to think about this, right? And having trials like the SARC trial that was done with the MEK inhibitor, those were really informative studies, not only about efficacy, but also how to run clinical trials in EHE, right? So it's I think, a very exciting time in that regard. But again, this is where we kind of need this collective collaboration to do it correctly.
And maybe a general question for the rest of the panel here. As you are seeing patients and they're inquiring about clinical trials, obviously it's going to be individual by individual, but do you have some general thoughts about the types of considerations that go into discussions with patients about whether to participate in a trial or not, and to select the right trial?
I think that in the sarcoma community specifically, but probably more general, I think it's really important that we have that conversation with patients. I think that when you don't have established, approved treatments, I am always a big fan of, recommending clinical trials. And I think it's important that we talk to each other. So, if Dr. Tapp has a trial that is not available at my site, I want to make sure that I know that, so I can talk with the patients and see if it's feasible, because I think ultimately we all win if we can enroll to these trials. And I think what Dr. Tapp was saying about the SARC trial with the trametinib, I mean, it really was quite remarkable how quickly that trial actually enrolled, and it was only involved in so many sites. But it's pretty remarkable, because I think we're all talking to each other, and we all want to, try to make this better for everybody. So
I I agree with Missy. I mean, when we have an EHE trial, we had the SARC study open. I mean, it was my go-to for patients that came to our center. Many of them came specifically for it. But I think that, you know, it offers the patient potential benefit. It offers us a chance to learn about the disease through the biopsies and correlative studies that are done as part of the trial. And so I think it is the best option for the patient and the EHE community. You know, certainly you have to factor into things like how far does the patient have to travel? Do they have the means to come and participate? And so those are real concerns. So we're constantly, you know, trying to look for resources to help support patients through trials because it can be quite a financial burden on them. So something that's important to consider as well.
Yeah, that's an important point, and I'll just kind of raise that to all of the attendees here. We have participants of multiple nonprofit organizations that might be able to help support efforts like that. So that's if clinicians are seeing that as a barrier to patients entering trial, let's get the word out because that's something the broader community might be able to help out with quite a bit.
And the only thing I would add is, you know, as part of a clinical trial, you often get the opportunity to try something you're not going to have access to in another way. The standard, or maybe I shouldn't say standard, the off-label treatments that we use routinely will be there. And if we, you know, obviously we hope and expect people to live, you know, as long as possible and have different opportunities to try as many treatments as possible. So if there's an opportunity to try something new as part of a clinical trial, we definitely encourage that as kind of our priority line if feasible.
All right, the next question gets into transplants. And you know, a lot of EHE patients present with lesions in the liver. And I'll ask the specific question here. If tumors are only in the liver, at what point is surgery or transplant recommended to prevent metastasis? Is transplant or surgery recommended if you have metastatic disease? What are the considerations? Big question.
This is always a tough one because, you know, I mean, we often do proceed to transplant if there's even metastatic or kind of multifocal, more than one spot within the liver. You know, if there's, you know, a bulk of disease in other spots, then it usually is not thought to be helpful. But sometimes if there's very small spots in the lung, we can consider it. But, you know, sometimes just because you can do something doesn't mean it's the right thing to do. You know, we know that sometimes this disease can be you know, not symptomatic and not progress. And we know that liver transplants are not easy and cause a lot of long-term effects. So, you know, the timing is definitely another one of those not one size fits all type approaches. And it kind of would be difficult to even put a perfect guideline together. The guidelines are to, you know, consider who's eligible for a transplant, but whether or not it's the right thing for an individual really has to take into account a lot of different factors in terms of how the disease is changing, what is the extent, and, you know, what are the anticipated long-term effects of living with a liver transplant.
All right, our next question. What are reasons to switch from or discontinue therapy to watchful waiting? So we've talked about going in the other direction, but what are your thoughts on treatment to watchful waiting? And when to make that decision and the basis by which that decision might be made?
Yeah, I think that's also a tough and nuanced question, but it's one we face all the time. And again, sometimes in more of the slow growing cases, you know, we'll start a treatment when, you know, we start to see growth in some of the tumors, and, you know, we'll keep people on that treatment for a long period of time to know if it's helping. But the hope is often that the treatment can kind of switch the tumor back into more of a slow growing or indolent phase, right? So a lot of times I think taking drug holidays and coming off of treatments are a good idea to see, you know, how well the treatment has helped. I mean, and the other thing is sometimes, you know, during those processes, you actually target, like we spoke about, any lesions patients that, may have had atypical growth or were in a tough location. And by really taking them away from the clinical situation, it's also a good time to try to back off some of the treatments to see how people will do, because, although we talk about a lot of our treatments as being well tolerated, that's a little bit in the eye of the beholder, and having to take medicine every day is difficult at times, right? And sometimes a little bit more difficult than what we think the disease would be doing to them.
All right, we've got a location question here. How rare is EHE in the brain? And are there specific treatments for brain EHE or special considerations?
I don't think I ever saw EHE in the brain, but I have seen like the skull or the bone involved, but I don't think I've ever seen that.
Actually, as a general point of curiosity, then, I know all of you have seen patients. Has anyone seen EHE in the brain?
Yeah, I mean, it's rare, but it happens. And a lot of times it's more incidentally picked up, right? So again, we don't always know if there may be small areas there that were there and, picked up for other reasons versus, are they new or progressive, right? So it also creates the challenges of, when you find them, are they something that need immediate attention? There's a lot of things on scans that can help you with that. But, we would think about all of our standard local treatments if need be for them, be it radiation, surgery, or the combination, and then also medical management, right? So it is, like Missy was saying, rare enough that it's not something we continually monitor for. But it can happen.
All right, we've got a question on the surgery side. And again, this is going to be, it depends question, I believe, but any thoughts you have on this would be very helpful. How likely is reoccurrence of EHE after surgery with clean margins? Could EHE show up in another body part after being totally removed from, say, a liver? And I'll just make a little note, because I work with a lot of people on the diagnostic side. Clean margins is oftentimes a call that's made that may not always be correct. But any thoughts you have on that topic?
When we have a patient that has a tumor removed, what I counsel, and I would assume many of my colleagues would as well, is there's always that risk that it could recur in the same spot, or it could spread and metastasize to another spot. And I think that it's important to kind of look at both. And I think, you make a good point about margins, and I'm certainly not going to get into like how big the margin has to be or anything like that. But I think that when the pathologist sort of mentions that there is what we call a positive margin, where there may be some microscopic cells left behind, I think that certainly would increase the risk of having a local recurrence. So we would certainly review those cases. I think it's important to review all of this with a multidisciplinary team. So we're medical oncologists, but we work very closely with our surgical oncologists, orthopedic oncologists, radiation, all of that.
Yeah, I would agree. And we, as medical oncologists, we always talk about, more advanced situations, or like we spoke about earlier, maybe tumors in multiple places, even though it may not be behaving aggressively. But there is a subgroup of EHE that just presents with solitary nodules, and those, patients are often cured with surgery alone, right? So that really would be the first treatment for them. So again, it has to do with these different subtypes of EHE and how they would present.
And we have a question that also came up in a similar version last year, but it's a question that arises a lot. So I think it's important to address it again. Patients like to do as much as they can to help their own health. And we get a lot of questions about diet or dietary recommendations and any benefits on EHE. And oftentimes one thing we hear is concerns about high sugar diets, because that has been raised as an issue for other types of cancer. Any thoughts on diet specifically with EHE or any risks with high sugar diets?
As with these other questions, I think it's hard because we just don't have a lot of great data to kind of discuss exactly, what might influence it. I tend to counsel my patients that just as if I were their primary care doctor, I'd like them to try to eat, a heart healthy, well-balanced diet, nothing too extreme, limiting processed foods. But I certainly don't recommend avoidance of all sugar and or anything extreme that kind of really negatively impacts their quality of life, or anything that's very expensive. There's a lot of things that are sold out there that are unfortunately very costly to patients. And so I generally counsel them, if it sounds too good to be true, it probably is.
Good words to live by, Dr. Davis. Thank you.
And outside of diet, any other, I know obviously there hasn't been studies on this, but anything you're seeing at least anecdotally on lifestyle, sleep, other things that patients have a little bit more direct control over that might be beneficial?
I know that in a general sense with cancer, I know there's a lot of data recently on exercise, and my institution has a program where we're starting to approach more patients about using exercise and counseling with physical therapists and that kind of thing. And I imagine that my colleagues here would maybe have a similar program. But it's really quite interesting. I think there's a lot of emerging data. So I think there's a lot more to come about that.
Yeah, we try to enroll all patients with sarcoma, so EHE and otherwise, to enroll in our study, where we give all patients a Fitbit and kind of monitor activity levels. And then we also have them complete regular sleep questionnaires. The Fitbit will also monitor that, and several other metrics like that, so that we can try to understand how those things correlate with patient-reported outcomes.
All right, we've got about 4 minutes left on the panel here. And so I've got a question I think it would be good to hear from each of you individually on this. And this might be a hard one to think about quickly, but I think it's an important question to get your view of where we sit here today, which is, where would you like to see research done to learn more about EHE in a capacity that's perhaps not being done right now, or if it is being done, you'd like to see sort of more investment in that area of research? It'd be great to hear from each of you about your thoughts from a patient perspective, where you'd like to see more effort spent on knowing more.
Is all of the above an option?
It is, yes.
I mean, I guess I would like to see, patients treated systematically, so that we could actually study and understand, because what I do at my institution may be different than my colleagues here. But it would be nice to kind of start collecting prospective data on everyone that we treat, because then I think we would actually have a much better understanding of how we're affecting outcomes, because there is so much variability, because each case is so nuanced. I think it makes it hard for us to make huge generalizations. So I think if we could spend money kind of creating prospective registries, where we kind of are able to track samples and learn about the disease that way, I think that would actually possibly be the most impactful.
Other thoughts?
I would agree. I mean, I think, really amazingly, we've learned a lot about the penetrance of some of the translocations and the signaling effects of that, right? And I think, that's really opened the door up to clinical trials that we're seeing. So, there is this, I'll use the word lightly, explosion in our understanding, but also treatments that we have, that we weren't even there 10 years ago. I think importantly, what I would also like to understand is why we can see some of the same genetic defects, but really different clinical behaviors in people, and why that is, and what are the mitigating factors, be it the relationship with the surrounding tissue, or, the tumor factors that are actually doing that. And the other thing I think that we need to invest in is to really better understand how the disease affects people, because when we think about studying some of these treatments, right, it's one thing to say we have a drug that can do X, but we need to show that it's clinically meaningful for people. And because this has such variation in how it affects people, just like Libby was saying with the registries, we really need to begin to understand how to design studies so we can show that effect, right? So all of that is kind of connected. But I think the community is moving forward in a lot of different these ways. So it's exciting, even though it's a rare disease. I mean, there's a tremendous amount of research and collaboration going on.
I think it's hard to pick one thing in particular because I think they're all really important and interconnected. But I mean, I think when you have limited funds, like I can understand that you kind of have to decide which comes first. But I think I would echo what my colleagues have said with the registry and kind of looking to see more about the natural history and sort of just getting patients together to learn more about the disease.
And I guess I would just totally echo those thoughts, but also add that, you know, referring to one of the questions earlier about kind of when the disease can change and become more aggressive, if we can learn scientifically what triggers that, either based on registry data and kind of a patient's, you know, situation at that time or exposures, or maybe more on a molecular level. This is why kind of getting biopsies and tissue, you know, hopefully someday we'll be able to learn what's the difference when things start to change quickly and how we can target that.
Excellent. And we're right at time. Thank you all for the participation. I would say what we've learned is this Ask the Expert panel is one of the most look forward to parts of what we do and all of the things we do. This is one of the best spots to get a lot of hard questions answered in a very short amount of time. So thank you all for participating.